Thank you. Let me see if this is okay. All right. I hope this is not going to be too sleepy for everybody here. So just want to thank the organizers. Thank you for the group here for asking me to discuss the guidelines-based approach on which patients should get IVC filters. I have no disclosures. And just want to say that, IVC filter placement is the alternative therapy. It's an alternative mechanical therapy to the standard therapy for VTE, which is obviously systemic anticoagulation. And the timeline for systemic anticoagulation is really divided into three phases: the initiation, acute or primary, and then the extended or secondary phase. The acute or primary phase really depends on how the patient presented, whether it's 3 months or 6 months, depending on what the hematologist would like to do. Being that it's a mechanical therapy, it started off first, as these therapies usually do, as a surgical technique. So in the 1940s and even before this, it was conceived of as a surgical technique. It was IVC ligation, compartmentalization, or IVC complication. Then in 1967, we went on to a jugular venotomy and placement of a moving Uden umbrella. And then in 1973, the advance was that the Greenfield filter could be placed with a venotomy from the jugular or the femoral vein. And then, of course, we had the first percutaneous placement of the Greenfield filter in 1984. Another advent was the retrievable filters, and it was in 2003 that the FDA approved the first retrievable filter, which was the permanent and retrievable filter, the Gunther Tulip. And then we had 13 devices, IVC filter devices, that had received approval by 2010. Of course, with all the technological and device-related innovations, there was increased utilization. And so we had 10 years from essentially 2000 to 2010 where the number of filter placements essentially doubled. And that was obviously in this country. And in 2010, it was more apparent that these devices were actually having some complications and some risks, and those were, becoming, coming more and more to the forefront just because of the number of filters being placed and longer implantation times. And so the FDA issued its first safety communication looking at this. And then in 2013, the American Society of Hematology also started its Choose Wisely filter campaign. And then 2014, again, the FDA renewed a safety communication, and then, of course, also required stricter mandates for reporting complications in the MAUDE registry. They also directed the trial that was recently reported in earlier this year, the PRESERVE trial. So, of course, the trends of filter use, if we just look at those over the last, say, 20 years or so, these are large retrospective databases, the NIS database. It shows that after 2010, after these campaigns, after the FDA safety warning, the number of filters decreased to about 9% every year. And same thing in the Medicare beneficiary database. Initially, from 1995 to about 2009, there was a significant increase, and then a decrease, by around 2015. And then in September 2020, the SIR clinical practice guidelines were published regarding IVC filter use in patients with thromboembolic disease. And this was developed in collaboration and endorsed by a number of different organizations that you see here. The American Society of Hematologists, they didn't endorse the guidelines, but they affirmed that these guidelines have value for hematologists. So this committee was composed of 11 panelists. You can see all the specialties here. And they used actually this American Academy of Orthopedic Surgery methodology, and spend a little bit of time looking at that. They came up with 18 recommendations, and actually 12 of them were regarding placement, 10 regarding the clinical scenarios in which IVC filter placement, is indicated, and then they had a few that were actually for retrievals. and reporting standards and things. But I'm going to spend really some time on those first 12. So the methodology was that they reviewed more than 3,200 abstracts, and then they sort of looked at these to see whether they would be meet some inclusion criteria and whether there was best available evidence based on whether they were randomized clinical trials or just observational studies. And they came up with 34 articles after all of this. And then they really sort of spent some time looking at the full text of these articles and then did a quality assessment and then basically forged the guidelines based on that. I just want to spend some time looking at, how they worded these guidelines, because I think it's they use the wording here to really, transmit, the number one, the level of evidence, and number two, to some extent, the quality of evidence. So when they say we suggest for or against, that meant either consensus or limited. So consensus, as you can see here, is that there's really no supporting evidence. Okay, and limited was that there is some evidence, or in the medical evidence in the literature, but they were low quality studies, and it was really when they had moderate or strong evidence that they said we recommend for or against. So even though we call them recommendations, they're really guidelines, and we really have to look at the language. And they then had a visual sort of scale of the strength of evidence. Okay, so if you had 4 bars, which none of the guidelines did, then that was the strongest level. There were some with moderate level, but most of them were actually as just really consensus, basically consensus of the committee members, what they thought was the best, evidence, or at least their sense of it, and then there were many of them were limited also, instead of actually, we only had a few moderate, and so we're just going to go over that. So this is a guideline that I think we probably would say, hey, look, this is the kind of patients that should have an IVC filter, right? Acute PE or DVT and absolute contraindication to anticoagulation. We see those patients, they may had a recent hemorrhage in the brain or something. But the best they could come up with is we suggest for, okay? Because they really weren't very good. There was just limited evidence for acute PE, and for acute DVT, actually, there was really no evidence for having placed an IVC filter in these patients. You would think that this is the one that almost everybody would say, hey, look, these are the patients that we should place filters in. But the evidence is just not there. There aren't really any randomized clinical trials for this. So they had to just say, we suggest for what we would think is a universally accepted, indication. The next 2 guidelines were in patients who actually had acute VTE and were undergoing anticoagulation and then developed a absolute contraindication within the first 3 months for A, and after the first 3 months, basically during the extended anticoagulation period. And actually, again, we suggest for because there really is no evidence. It's just all consensus, expert opinion. Okay, and actually for patients who have who've undergone 3 months of anticoagulation and are beyond that, they suggest against, with rare exceptions, as they're sort of qualifying. So again, really no evidence to say that there is that these patients would benefit from IVC filter placement. Here's another one that we commonly say, oh, look, somebody who's failed anticoagulation, those patients should get a filter. So in somebody with an acute VTE and they've undergoing anticoagulation, now they experience a recurrent event, another episode of DVT or PE. And again, there isn't much evidence here, only 1 star, but they suggest against IVC filter. All right, so instead of putting in the filter, they suggest that you first document and confirm that there's really truly been an event that is basically a recurrence, that the patient did have a new DVT or a new PE, and then address all the issues around anticoagulation failure first. Did the patient take their meds? Are they taking the right amount of their anticoagulation? Did they run out? Should they change their dosing? Should we change the agent? So instead of just going right to the filter, first look into these factors, and then maybe. Recommendation 5 is with patients who have acute VTE and are being treated with anticoagulation, should we put a filter in those patients? In other words, is adding a filter to patients who are already on anticoagulation, tolerating anticoagulation, would that reduce the morbidity and mortality associated with PE? And actually here we recommend against, and they have moderate level of evidence. And that's because this is coming actually from 3 randomized control trials, 2 of which PREPIC 1 and PREPIC 2. And in those patients, and there was another one with patients who had cancer diagnosis, that those were negative trials. That adding IVC filters in those patients, they were already on anticoagulation, you added a filter, and actually there was no difference. So in patients already being treated with anticoagulation, adding a filter doesn't really help. And so that's why they came up with recommend against moderate level, because now we have 3 randomized controlled trials. This is the flip side. In patients who already have a filter for whatever reason and no other indication for anticoagulation, does anticoagulation help? And they could not recommend for or against. It was really just consensus. So it really depends. If they really do have, I think, VTE, probably put those patients on anticoagulation. But if they already have a filter, it doesn't seem to help. We really don't know. This is the indication that is in patients who are undergoing advanced therapies. The guideline now for number 6 is for PE, 7 for acute DVT. Should those patients have a filter? And there are some observational studies that we have here. They're not very big, but basically they felt that there was limited evidence, and they suggested in favor of IVC filter placement. I think they recognized that these were patients with variable presentations. They're getting different kinds of interventions, and I think they left it up to the operator. But basically, they said we suggest 4. All right. So, but at least this was more than just consensus. There was a little bit of evidence to say yes. What about these indications? These are traditionally prophylactic indications. In some of the older studies, these were 20-25% of patients who were getting filters. Okay, and actually, if you look at these 2 guidelines, number 8 and 9, in trauma patients without acute VTE, we recommend against moderate level. So pretty good evidence, right? Better than what we were seeing before. All right, recommendation 9, the level of evidence is rest consensus, but in patients who are having major surgery who don't have any prior history or prior acute DVT, we suggest against. So these are the 2 prophylactic indications, and they suggest against them. Especially in these patients with trauma. And that's because now there's much better ways of actually, prophylaxing these patients, much better ways, I think, than we had before, better protocols. And also knowing that IVC filters don't reduce mortality and that there's a, finite but increased rate of DVT. All right, what about patients who are going to have an IVC filter placement? Is there a particular technique? And actually, they could not recommend for or against any specific technique. So fluoride-guided, IVIS, jugular, femoral, and I think this makes sense, and again, this was just consensus. So I just want to spend just a couple more minutes here on just these recommendations, and actually the recommendations that we that had the greatest degree of evidence were those that were against IVC filter placement. So routine placement in those patients already tolerating therapeutic anticoagulation. Again, this is from the PREPIC trials. And then prophylactic patients, especially in trauma patients without known DVT. And same thing with major surgery patients. All right, so this is against IVC filter. So not prophylactic, not in patients who already have tolerating anticoagulation, and not in those who are having major surgery. These are the recommendations for IVC filter placement. Again, these 2 are the ones that we would think almost everybody would say, hey, look, these patients need a filter, acute PE or DVT, and absolute contraindication anticoagulation. We just don't really have great evidence for it. And patients who develop a contraindication, certainly in the first 3 months, I think is probably a good idea, but again, just consensus level of evidence. And then those patients who are having advanced therapies, does it help? Well, I think they say that it probably would be a good idea. And I think this is mostly really dependent on the operator. All right, so I think just to save a little bit of time, those are the guidelines from SIR, and they had published those before in 2006, so the 2020 was an update. But going beyond the guidelines, what would we do? Well, I think if you really feel that somebody needs a filter, I think it's really important to have a multidisciplinary discussion. Usually part of a PERT group makes a lot of sense, and just weigh the risks and benefits, case by case, and then make sure we document that well. But of course, the second part of this is if you do place a filter, make sure the patient is following up and is getting it retrieved. Okay, thank you for your time. Much appreciated.
Thank you very much, Dr. Patel. That was excellent.